Good morning, everybody. Thank you for giving me the opportunity to present my talk on laryngeal electromyography in the pediatric population, the Australian experience at your 8th World Chinese Otolaryngology Head and Neck Surgery Conference today. I would like to especially thank Dr. Alice Yu for this opportunity. The topics that I'll be covering this morning include vocal fold palsy briefly, the role of pediatric laryngeal EMG, the logistics of it, as well as the practicalities. Vocal fold motion impairment is a clinically heterogeneous disorder that is challenging not only in terms of diagnosis, but also its management. Vocal fold palsy is the second commonest cause of congenital stridor. It may result in airway, speech, and swallowing dysfunction depending on the position of the vocal fold. Recovery depends on the etiology of the paralysis, but it is really difficult to predict clinically. Dysphagia tends to recover prior to the return of vocal fold mobility. While there is a higher rate of overall recovery in those with iatrogenic vocal fold palsy in children compared to the adult patients, recovery tends to be longer and more variable in children. Laryngeal EMG was first reported in 1944. In 1987, it was first performed in children. Even in the adult population, the clinical role of laryngeal EMG is disparate between medical centers. There is no standardized guideline on what constitutes a well-trained electromyographer or the appropriate application for laryngeal EMG. To date, there is no validated studies in the pediatric patient. The adult model on the vocal fold palsy pathophysiology is based on iatrogenic injury, and this may not be applicable in the pediatric population. The timing of the intervention is guided by the patient's symptom, safety, and prognosis for recovery. Vocal fold motion impairment can be paralysis or fixation or scarring. The differentiation between these is important because the management of them is different. Scarring may be subtle and difficult to differentiate. It may also coexist with paralysis. In addition, clinical examination may be obscured by compensatory supraglottic function, obscuring evaluation of the vocal fold motion and glottic closure pattern. The integration of history, laryngeal examination, laryngeal EMG, plus or minus radiology gives the most complete picture to guide management in terms of the timing and type of treatment as well as counseling patients. Laryngeal EMG can be used to diagnose movement disorders, differentiate between structural, like posterior glottic stenosis, ankylosis, or arytenoid dislocation, versus neurological causes like motor neuron disease, vagal or recurrent laryngeal nerve paralysis. It also localizes the site of neuromuscular lesion, quantitate the degree of paralysis, document progressive denervation, and prognostication the potential return of function. Its greatest use is to accurately predict a poor functional outcome. It can also be used to detect signs of incipient recovery. The integrity and degree of renovation can be assessed by the recruitment pattern, estimation of the number of motor units available for recruitment, the size and configuration of the motor units. These are all important in decision making. Laryngeal EMG is most useful in predicting the failure of recovery, and it is not as useful in predicting the return of normal motor function. The positive predictive value for poor prognosis is reported to be 90.9%, and it is recommended that a laryngeal EMG suggesting poor outcome should provide some basis for earlier definitive intervention in these patients. In terms of the negative predictive value of laryngeal EMG, if the testing done 6 months post-op demonstrated no activity, then nerve function is unlikely to return.
Serial laryngeal EMG can be used to monitor recovery and provide some prognostic insight.
At Perth Children's Hospital, we have a team that comprises of myself, Dr. Kava, the pediatric neurologist, as well as a pediatric neurophysiologist. This is based on the model where I did my pediatric fellowship at CS Moss Children's Hospital in Ann Arbor, Michigan, as well as Dr. Kava's fellowship at Sick Kids in Toronto.
The equipments that we use include the keypoint focus compact EMG machine as pictured here, and a 50mm disposable concentric bipolar needle, a connector. The slimmer wide attachment goes to the needle, whereas the larger attachment is attached to the machine, and a disposable ground plate electrode with a lead. So the sticky part goes onto the patient's shoulder and the black bit goes to the machine. The logistics of laryngeal EMG is complicated because it involves a lot of planning and it involves so many people. I need to pick a day where I'm available, my pediatric neurologist is available, and the neurophysiologist is available as well as the patient. If it's not on one of my regular operating day, I need to ensure there is a list that's available for us to perform the procedure. Fortunately, my pediatric neurologist has now moved her day to my regular operating day. I need to make sure that my patient is optimized preoperatively. Often they have lots of medical comorbidities and they will need to see the high-risk anesthetist prior to the procedure, and I need to have a post-operative disposal plan, and this usually involves a pediatric intensive care unit bed. I often send reminder emails and texts to my team members so everyone's on time on the day of the procedure. I usually do not find out which anesthetist is doing the list. It can sometimes be someone I've not worked with, so I need to make sure the anesthetist is comfortable to perform the procedure. I need to make sure that there's equipment available, but our neurophysiologist is really good at checking that. She's very organized. Most importantly, I need to fashion the laryngeal EMG electrode. I usually do that the night before because the list is usually in the morning. After the procedure, I usually give the parents a quick overview of what we've found, and once the report is finalized, I usually see them in clinic and we have a more concrete plan in terms of ongoing follow-up with ENT, speech language pathologist, dietitian, and or occupational therapy.
On the left, you see the disposable concentric bipolar needle that we use, but the belly, the white portion where the laryngeal alligator forceps grabs on, it can be quite slippery and it occupies quite a lot of space, even with the Parsons laryngoscope that I use. As you can see here, and sometimes it can be quite tricky for the insertion.
As you saw in the previous slide, how thick the connector is, I often do struggle to fit that through the Parsons laryngoscope. So now the day before the procedure, I will use the 11 blade to shave the belly of the connector down without exposing the copper wiring underneath the insulation. And then I'll remove the white tip on the IV cannula, and then using the scissors to cut it lengthwise, I will fit the transparent cannula onto the actual connector and then using the micropore tape to stiffen the whole complex. So now I can use this freehand without the need for an alligator forceps. This gives me better control as well. I'll be showing a series of videos on the placement of our modified laryngeal EMG needle. This is on a child with a left vocal fold palsy from a cardiac procedure. The needle was placed freehand into the normal right thyroarytenoid, and the recording was obtained. Then the needle was placed into the right normal PCA. And then I moved on to the left thyroarytenoid. This is the paralyzed side. Finally, the needle was placed in the left posterior cricoarytenoid. You can see me moving the needle around under the instruction of my pediatric neurologist. This is especially important when there is electrical silence to ensure that there are no other motor units that can be picked up. I usually do this at least 3 times in different positions to make sure I'm not missing anything. There are concerns that during spontaneous ventilation, the depth of anesthesia may affect the presence of muscle motor unit action potential activation, with the potential for brief duration and low amplitude motor unit action potential activation under GA. The use of muscle relaxants are avoided for obvious reasons. Inhalational anesthesia is routinely used for airway endoscopy due to the ease and comfortable induction, the speed because of the reduction of induction time, maintenance of stable breathing, and a simple non-invasive evaluation of the inhaled agent. However, it is thought to potentially affect laryngeal movement. There are concerns that different concentration and duration of inhalational anesthesia may affect laryngeal movement, modify laryngeal EMG finding, produce spurious abnormalities, and based on literature pertaining to spinal surgery, some authors have recommended total intravenous anesthesia, TIVA, for better control of the duration and depth in laryngeal EMG. TIVA acts rapidly and independently from the alveolar ventilation. It can be administered from peripheral locations away from the site of airway instrumentation, lessen post-op nausea and vomiting, reduces airway reactivity, and hence laryngo and bronchospasm in children. However, it may be difficult to balance adequate depth of anesthesia and stability of spontaneous respiration in children during airway endoscopy. Dosing may be more demanding as high infusion rates are sometimes necessary to provide the desired plasma concentration. Gazaz M. et al.'s animal study in 2018 used monopolar needle to the PCA muscle, and they found that the mean laryngeal EMG amplitude during TIVA is 66.9% of inhalational anesthesia. There is no significant differences in the mean amplitude or the mean burst duration. There is consistent pre-inspiratory PCA contraction with both anesthesia, but TIVA took longer, 45 to 90 minutes compared to 10 to 15 minutes with inhalational anesthesia. There is controversy as to which electrodes to use, and there are many different electrodes reported in the literature. Intramuscular or surface electrodes. In children, it's generally intramuscular, bipolar versus monopolar, concentric or not, hooked wide or not, or paired subdermal electrode.
Our preferred electrode is the 50mm disposable concentric bipolar needle by Natus Medical Incorporated, which is also advocated by Dido to precisely localize the recording area. The data interpretation is done exclusively by Dr. Kava, our pediatric neurologist. She is EMG trained and she's present in the operating room so that the acoustic profile, the quantitative, i.e. the amplitude and duration, as well as qualitative analysis of the electrical activity's morphology can be analyzed effectively and correlated with the respiratory phase and with what I'm doing with the laryngeal EMG electrode. Laryngeal EMG records electrical activity produced by the laryngeal muscle, and this recording is also amplified and displayed on the screen as well as played on a loudspeaker to allow for visual and sound analysis. It gives information about the neuronal input into the particular muscle tested, as well as the integrity of the neuromuscular system in the larynx by recording action potentials generated in the laryngeal muscle. It should always be interpreted in the context of the clinical picture. Here is an example of the EMG recording that is seen from the EMG machine. There is large motor unit action potential indicating denervation. This next slide here is showing an EMG recording of denervation fibrillation at rest. In terms of side effects, it's really minimal. It's a very safe procedure. There is small risk of bleeding and edema, usually in the compromised airway. The main limitation of laryngeal EMG is the possibility of false negative recordings. We attempt to overcome this by at least 3 repeated insertion when electrical silence is encountered. And also I'll be instructed to move the electrodes by Dr. Kava. The need for teamwork may also be a barrier, but we believe the presence of an EMG trained neurologist in the operating room for interpretation is essential to analyze the acoustic profile as well as the qualitative and quantitative electrical activity. Despite considerable refinements in methodology and instrumentation, laryngeal EMG has not been widely adopted in routine clinical practice because ENT surgeons are frequently not qualified to interpret electrical activity arising from the skeletal muscle, while neurologists lack the necessary skills and confidence to insert electrodes atraumatically into laryngeal muscle. In children, it is challenging as laryngeal EMG requires general anesthesia due to compliance. The placement of the electrodes depends on the surgeon's knowledge of the laryngeal anatomy, as patients are unable to phonate to confirm the position. This is why Peekaboo reported in 1998 that the skills necessary to perform consistent EMG sampling of the laryngeal muscles is not easily obtained by the occasional laryngeal electromyographer. The operating room artifacts may also interfere with the sensitive instruments used to record laryngeal muscle activity, resulting in difficulty assessing spontaneous activity in a resting state. The environment can be difficult to be manipulated to control the 60 Hz and other electrical interference. However, newer EMG equipment reduces the extent of background noise to an acceptable degree. Many of the studies published have small sample size, are retrospective in nature, included patients with heterogeneous population, and lacked a blinded neurologist or neurophysiologist. While monopolar electrodes are commonly used, some reported bipolar electrodes Many authors sampled mainly just the thyroarytenoids, while some sampled only the PCAs and others sampling both. The anesthesia used were variable, with inhalational being the preferred method. There is also a lack of consistency using serial measurements or longitudinal follow-up to judge the accuracy of laryngeal EMG. There is generally a lack of standard application as well. In summary, laryngeal EMG is a safe and useful diagnostic procedure. It supplements endoscopic data as well as the clinical picture, and this can assist in patient decision making. It does require significant collaboration, and at my hospital it is still a work in progress. I would like to end my talk by extending my warm invitation to you all. Our 74th ASONS conference will be held in Perth in 2024, and I hope to see you here. Thank you for taking the time to listen to my talk on a Sunday morning.